speakers and guests. I would like to welcome you as a representative of FEMA Regional Institute of Indonesia and also the Masters in Medical and Health Professions Education, Universitas Gadjah Mada. Thank you very much for joining us today in the international webinar in conjunction with Professor Titi Savitri Prihatiningsih inauguration with the theme Medical Education and Health Services as Cost-Adaptive Systems, Its Implications. The webinar will run for about 3 hours, so hopefully you would like stay in a meeting room to have a fruitful discussion, and perhaps you would like to share also your experience. We have invited here our speakers, honorable speakers, Professor Titi, Professor Charles Bullen, and Professor Young, and Professor Genevieve, and also Professor Thomas will joining us later on. And thank you very much for everyone. I think the participants from the list of participants, it's not only from Indonesia, but also from other countries throughout Southeast Asia and also Asia. And hopefully we will also reach out for a wider community of practice among us, health professionals, educators, to bring out the best practices on how to improve our quality in medical education. At first, I would like to introduce the round for today. Next slide. Yes, myself, I would like to introduce myself. My name is Rahmadia Nur Hidayah. You can call me Rahma. I'm the moderator for today, and I would also like for you to invite you later for the discussion, should you have any questions or comments regarding the presentation. And next, I would like to present about the agenda for today. The webinar will be started by the welcoming by Director, Associate Professor Dr. Yoyo Suhoyo, Master of Medical Education, and continued by an opening speech by Professor Yodi Mahendra Datta, the Dean of the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. And after that, there are 5 speakers who will present and share their expertise. The first is from Professor Titi Savitri Prihatiningsih, Can we reform our accreditation system? And then will be continued by Professor Genevieve Monyu about planetary health, and Professor Charles Bullen about social accountability for medical schools excellence measures. Continued on by Professor Thomas Chako about experiences of accreditation for medical schools in India. And the last speaker is Professor Dr. Yong Rafidah Abdul Rahman, who will present about the accreditation experiences in WPAME countries. And all the speakers would like to ask for questions or give comments, and we will have the discussion at the end of the webinar. And if you have questions during the webinar, you can also write down in the chat box. So please do not hesitate to write down your comments or ask questions through the chat box. Dr. Yoyo Suhoyo is already here, and he will welcome you, our guests and speakers in our webinar. Please, Dr. Yoyo, the screen is yours.
Okay, thank you, Rahma. Can you hear me? Okay. Good morning, everyone. I'm Yoyo Suhoyo, the Director of FEMA Regional Institute of Indonesia for Educational Development and Leadership. Welcome to all of you, speakers, audience, and of course, our deans, Prof. Yodi, for joining this webinar. This webinar is a part of our initiative to discuss, to develop, to improve medical and health profession education. And for today, it is more special because it is our celebration for the inauguration of professorship of Prof. Titi Savitri, Master in Medical Education, Master of Arts in Public Health, and PhD as a professor in medical education. So congratulations again, Prof. Titi. And then to all speakers, Prof. Genevieve Moni, Prof. Charles Bullen, Prof. Thomas Cheko, and Prof. Yong Rafidah Abdul Rahman, thank you very much for your kindness to be part of this webinar. It is such an honor for all of us here for having you in this webinar. And to our deans, Prof. Yodi Mahendrata, thank you very much for your time to provide opening speech in this webinar. And to all of you, our audience of this webinar, enjoy this webinar and let's learn and let's strive together for better medical and health professional education. That's all. Thank you. Back to you, Rahman.
Thank you very much, Dr. Yoyo, for opening the webinar. Next, we will have Professor Yodi Mahendrata as the Dean of the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. Professor Yodi, the time and screen is yours.
Thank you, Mbak Rama. Assalamualaikum warahmatullahi wabarakatuh. Distinguished guests, esteemed speakers, colleagues, friends, and participants. It's an honor and privilege to welcome you all to this international webinar on medical education and health services as complex adaptive systems, hosted by the Regional Institute of Indonesia for Educational Development and Leadership at our faculty here at Gadjah Mada University in collaboration with the Southeast Asia Regional Association for Medical Education. Now, today's webinar is special. It holds profound significance as it coincides, as Dr. Yoyo already mentioned, it coincides with the inauguration of a true visionary leader of change in Indonesia, Professor Titi Savitri. Professor Titi Savitri has been at the forefront of transformative efforts, spearheading advanced curriculum development and accreditation system. Her dedication to elevating medical education in our country has not only left a mark, but also served as a beacon of inspiration for educators and leaders worldwide. Our distinguished speakers, experts in their respective domain, will delve into critical discussions surrounding medical educations and health services as complex adaptive systems. We are privileged to have the Vice President of the World Federation for Medical Education, Professor Genevieve. We also have Professor Charles Bullen, an international consultant in health system and personnel. We have Professor Thomas Chako, Executive Committee members of CRMA. And we have Professor Dr. Yong Rafida Abdurrahman, who's the Deputy Dean at the Faculty of Medicine, Saberjaya University College of Medical Science. So I would like to extend my deepest gratitude to our experts, to our participants, and the organizing team for their dedication and enthusiasm in making this event possible. This event is not just a webinar, it's not just an academic gathering, it is a collaborative platform designed to empower our MHPE students, our MHPE alumni, our FAMER Friendship Fellows, and all participants to become agents of change. By fostering a community of practice, we aim to inspire the educators and practitioners who aspire to lead change in medical and health profession education in Indonesia and Southeast Asia. So together, let us embark on a journey of discovery, collaboration, and empowerment, driving positive change in medical education and health services in Indonesia, Southeast Asia, and beyond. Thank you, and I wish you all an enlightening and inspiring webinar. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you very much, Professor Yodi, for the opening speech. And hopefully, as you said before, this webinar will give insights and lots of motivation for the practitioners across Indonesia and Southeast Asia. Now I'd like to invite our first speaker, our main speaker, Professor Titi Savitri Prihatiningsih, our teacher. Professor Titi Savitri Prihatiningsih is a professor in medical education and bioethics at the Department of Medical Education and Bioethics Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. She is a former dean in FMPH and UGM for 2012, and previously also served as a Vice Dean of Academic Affairs at the same faculty. She has been holding several prestigious positions and many international experience and also national experience, such as a General Secretary for the Indonesian Association of Medical Education Institution in 2007 up to 2011. And also she was a council member of ONQA in 2013 and 2017. Now she is currently the president of CRAME, the Southeast Asia Regional Association in Medical Education, and she was the member of Education National Standard Body, or BSNB, for 4 years, up to 2018. She has been recognized as a senior and experts in leadership and organization in higher education, and also as a task force international accreditation and social accountability. She completed her PhD in University of Dundee, UK, and she has also been actively teaching in our Masters and Health Professions Education program. And with lots of doctorate students and master students as her former students, I knew that she's been inspiring all of us to improve our practice, especially in leadership, accreditation, and social accountability. I would like to invite Prof. Titi, since this webinar is also to celebrate her inauguration and in professorship. Prof. Titi, please, the time is yours. Thank you.
Okay, Dr. Ahmad, thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Honorable and distinguished speakers, and also all my colleagues from the department, the Dean and the Director of FEMER, thank you very much for organizing this event. It is really a very big honor for me, and I owe to all of you for allowing me to be engaged in the development of medical educations. I have been given a topic.
Pertama ke hati ya.
Is
Terus
it
yang
clear?
si interaksi obat, nanti kalian teh nggak usah terlalu takut.
I'm sorry, there is. Okay, I have been given a theme. It is a questions. Can we reform our accreditation systems? And actually, I will leave other speakers to answer these questions. So there are 3 topics that I would like to discuss here. First is medical education as complex adaptive systems, and then accreditation within the complex adaptive systems, and also the way forward. This is an article that really struck me to start thinking about complex adaptive systems. This article is written by Van Aarde et al., and it is just recently published in March 2023. It is entitled Complex Adaptive Systems in CanMed 2024. In this article, Van Aarde et al. Started to introduce that medical education is in fact a complex adaptive systems. Therefore, we need to prepare our physicians to be able to cope with this adaptive system. And therefore, we need to also change the way we educate. Even also we change the competencies or modify the competencies to be able to prepare physicians to face the complex adaptive systems. This is also another article by William B. Rose. He wrote about healthcare as a complex adaptive systems, implications for design and management. And this also struck me that the complexity that our healthcare system is now facing, and we already have experience when there are many disruptions. Just very recently, the pandemic COVID-19, the war, etc. And in managing the complex adaptive systems, leadership is more important rather than incentive, power, or command and control. And also there is another article which has been around for a while. It entitles Health Professional for a New Century, Transforming Education to Strengthen Health Systems in an Interdependent World. I like very much this article because it wakes me up that health education and health system is in fact interdependent. They are not two different systems. And in this article, Frank et al. Propose which is called system framework. This picture demonstrates the very close interlink between education system and the health system. Both of them are interdependent. We cannot just talk about medical and health profession education system on its own, or we cannot just talk about the health system on its own. So it's not a dichotomy, but it's one interdependent system. So we now look at what do we mean, or what is the definitions of complex adaptive systems. I cite two different authors. The first is from Samut Bocini in 2015. She wrote that complex adaptive systems consist of diverse components called agents that are interdependent, act as a unified whole, and have the ability to learn from experience and to adapt to change in the environment. Another authors explains complex adaptive systems. It means implying diversity with a great number of nonlinear connections. So nonlinear becomes a keyword between a wide variety of elements. Nonlinear connections shows the difference between complex and simple system. In simple system, the connection is linear. It is more predictable. But in the complex system, the connection is nonlinear. And then adaptive implies the capacity to learn from experience and to change within a changing context. And the word system means a set of interdependently connected agents. Characteristics of complex adaptive system, as written by Rose, he mentioned that complex adaptive systems, they are nonlinear and dynamic. And as a result of this situation, system behaviors may appear to be random or chaotic, and they do not reach fixed equilibrium points. They are also composed of independent agents whose behavior is based on physical, psychological, or social rules rather than the demands of the system's dynamics. Because these complex adaptive systems consist of a lot of agents, and each agent has different needs and desires, and it reflects in their rules, and they are not homogeneous. So their goals and behaviors are likely to conflict. In response to this conflict or competitions, agent tends to adapt to each other's behaviors. Agents are intelligent as they experience and experiment, and they gain experience again. Agents learn and change their behaviors accordingly. Thus, overall system behavior inherently changes over time. The complex adaptive systems result in self-organization. Behavior patterns emerge rather than being designed into the system. The nature of emergent behaviors may range from valuable innovation to unfortunate accidents. And what is interesting is there is no single points of control. System behaviors are unpredictable and uncontrollable, and no one has the power and is in charge to control, to command the whole agents in the system. Consequently, the behaviors of complex adaptive systems can usually be more easily influenced than being commanded or being controlled. So if we look at the medical and health profession education, we can see that to organize, to arrange, to deliver this education, we involve lots of stakeholders, lots of agents. And between those, they are all interconnected and interdependence, and they are all influencing each other. So this is an example. I took this slide from Professor Janet Grant's presentations in 2018. We can see that in delivering medical and health profession educations, be it at the undergraduate, postgraduate levels, or continuing professional development, we involve a lot of agents, a lot of stakeholders. We involve regulators, we involve Ministry of Health and Education, we involve professional organizations. Regulators can be medical councils, accreditation agencies, also research institutes, health service planners, community. Also, we involve clinicians, students, teachers, medical schools, universities, other health professions. We can name it and add a long list of the involvements of other agents like local governments, associations of teaching hospitals, associations of medical schools, medical associations, etc. So a lot of stakeholders are involved in the delivery of medical and health profession educations. So now accreditation, I believe that everybody has encountered with accreditation to some extent, and because medical schools, health profession education, they are part of the complex adaptive systems. So our accreditation is also working within a complex adaptive systems. I try to find what is the definitions of some terms related in the accreditations. And from it's quite a note publications by UNESCO, written by Flasino et al. They wrote that in much contemporary discourse on educations, the word quality is frequently mentioned, although it is rarely defined. So if you look at in the literature, there are a number of publications trying to define quality. So we can find many definitions of quality, but sometimes also we talk a lot about quality without trying to define what we mean by quality. And also standards and criteria are among the most confusing terms. Quality assessment, quality measurement, and review of quality are all taken for granted to be synonymous with evaluation, especially when there is an external element to the procedures. Also, an evaluation report is sometimes called audit report, assessment report, self-evaluation. Institutional audit is also sometimes considered as institutional review, and peer review is considered the same as external review. Some people say call it accreditation is a peer review exercise. So defining quality is a question of measuring human achievement. It is technically a problematic task. Those involved in the definition of terms and thus in making decisions should be aware of and sensitive to the difficulties and implicit subjectivity in defining and measuring achievement. So evaluating human endeavor, assessing human endeavor is not an easy task. And assessment is in itself a socio-political activity. Defining assessment procedures, extracting information from the process, and then taking decisions, all these processes have social and political implications and may have far-reaching social consequences, intended and unintended, positive and negative. A medical school that is not accredited, it can have social implications, personal implications, political implications, or the other way around. Medical schools that is considered to have an excellent accreditation, they have also consequences. So in search of definition of quality, there is literature, a publication wrote by Schlinder et al. They try to synthesize different definitions of quality within a higher education context. And they come up with this beautiful conceptual model of quality, depicting broad and specific strategies for defining quality. So, according to these publications, quality can be seen from 4 different perspectives. The first perspective is accountability or accountable. A medical school, health profession education institution is considered having quality when they are accountable to their stakeholders for the optimal use of resources and the delivery of accurate educational products and services with 0 defects. If we take this perspective, accountability perspective, as our definition of quality, consequently, the indicators or the criteria that we look at is more on the sufficiency of facilities, on the student preparedness for employment, procurement of quality resources, and also focus on continuous improvement. Another perspective of quality is fitness for purpose or purposeful. So a medical school or a health profession education institution is considered of having a quality education when they meet their purpose. And what is their purpose? They have a mission, vision to improve the health status of the community. They have vision and mission to ensure the improvement of the health status in their catchment area. So if you look at the quality from the fitness for purpose perspective, then the criteria will be fulfillment of vision and mission becomes the main criteria for judging to what extent a medical school is having quality or not. Also achievement of standard attainment of institutional goals. Another perspective is transformative. In this perspective, quality is seen when we have positive changes in the student learning in all domains, personal and professional potential. If we use this transformative education as our perspective, our way of looking at quality, then our criteria will be learner-centered approach, clarity of outcomes, then outcome-based education becomes the main criteria, development of critical thinking, student engagement. Another way of looking at quality is being exceptional, has distinctiveness. So a medical school is seen of having quality when they have distinction, when they have excellence. And in this perspective, we look at quality from the medical school reputation, prestige, ranking, credibility, etc. So there are 4 different ways of looking at qualities according to Schlinder et al. Okay, so what is the way forward? So I just would like to ask you all to reflect. So what is the purpose of a national accreditation system? Are we looking for an excellent a reputation of university, reflecting in the university or medical school ranking? Or are we looking at the fitness for purpose? We want the medical school or the health profession education institution to serve the needs of their population, to serve the health needs of the community? Or do we want to see that the medical schools is successful in transforming the students in developing their talents, or we want to see the medical school of being successful in making sure that all the graduates get jobs in a shortest time. So what is the purpose of a national accreditation system? And why does it matter? We all know that accreditation requires lots of resources, not only from the government side or from the accreditation agency side, but also from the school, from the institution side. When they're going to have an accreditation visit, or when they have to re-accredit, they need to prepare all the documents. They need to prepare a lot of things, which also drain the resources of the schools. So why does it matter to be accredited? Is this what we are aiming for? That the diversity of the inputs, when they come into our school, they become uniforms, like robots. Now there is a growing pessimism about the university, about our education system. Michio Kaku, one of the greatest scientists, mentioned that every child is genius, but the society crushes their curiosity. So instead of making or developing the talents of every student, the university crushes the talents, the curiosity, for the sake of uniformity. Again, now it's really there is a growing concern, also especially in the US. There are many students who have debts when they graduate, because the cost of higher education is getting increasing. And also we cannot forget that now we have a very advanced development of information technology. It makes people can learn anytime, anywhere, at the pace of their own. So how can we accredit such learning process? Also, the facts that in many places, not only in Indonesia, but also in other Southeast Asian countries, also in the whole world, we can see there are so many poor community, poor society, and the increasing discrepancies, between the have and the not have. Also, the fact that especially we know that the WHO already declared, in 1978, Alma-Ata Declaration, to have a primary healthcare as the backbone of health services. So it brings the health services close to the community and emphasizes on promotion and prevention, health education, early detection, and of risk factors. These are the context of the health systems that we have now. Also, there are huge discrepancies in healthcare system, we know, between the rich and the poor countries, between the rich and the poor societies. So, do we need to reform our accreditation system? Again, I will only ask the questions and other speakers will provide the answer. Do we need new definitions of standards of medical and health profession educations, definitions of quality in medical and health profession education, new definition of accreditation, self-evaluations, external review or external evaluation, or the evaluation framework? Do we need a different approach, different methodology in assessing the quality of medical and health profession education? Thank you. So I only ask questions, and we have very highly experts speakers who will answer those questions. Thank you very much for your kind attention.
Thank you very much, Prof. Titi, for sharing very insightful presentation, which perhaps I didn't even think about before this presentation. Congratulations once again, and thank you for sharing with us. I would like to invite all the attendees here to perhaps to ask questions, or perhaps you would like to ask something that you would like to clarify or give comments, please. Would you like to ask questions, or just write it down in the chat box or raise your hands? Any questions or comments from the audience? You can raise your hand or either write them down in the chat box. I think the issue of how the accreditation seems like the most important things for all stakeholders, Prof. Titi. They always think that the result of accreditation is something that they aim for, and sometimes forgetting that it is all about implementing or delivering quality. And since the definition of quality itself, and also what are the standards and how do we say label the results of accreditation as something representing the actual quality of education. And I think that's what most people are thinking about. I received questions actually from people who were not able to join the webinar, and they asked about how to actually use or deem the accreditation results as an input or feedback for the stakeholders involved in the education. So not only for the medical school itself, but let's say for the association of medical schools or the government, the regulator, and to actually follow up on that results and improving the specific aspects of what needs to be improved in the accreditation. What do you think about that, Prof. Titi? How to actually deliver? The one who asked me this question actually use a more like humble and down to earth standard for accreditation, and how it actually bridging the results of accreditation into something that is actionable as an improvement for the medical schools. Please, Prof. Titi.
Okay, thank you very much. Again, all the terms that we use in the quality assurance or accreditations, like standards, criteria, performance indicators, quality indicators, also accreditation, and then self-evaluations, external evaluation, or site visit, etc. All those are social constructs, and social constructs means that it depends on how we define. If we want that the accreditation results give a better impact to the not only to the schools but also to the whole education system, but also to the community, we can make it. We change our regulation. Again, first we define, change our definition, and then we change our regulations. Yeah. So I think nothing is impossible. It's the consensus. Yeah. In fact, standard is consensus of best practices among us. And when we talk about standard, when we set standards, in fact, what we try to do is to ensure that standards can be achieved by the majority of the population, of the people. It is not wise if we set a standard that can only be achieved by a small number of populations or small number of schools. So when we talk about standard, it's consensus among us. What we think it's good practice, best practice. So again, all of these terms are social construct, and it's changeable. It depends on us. It depends on our agreement, our consensus. But the problem is in the complex adaptive systems, sometimes consensus agreements among stakeholders are not easy to achieve. That's the challenges. Yeah, because every stakeholder, they have their own goals, they have their own interests, which sometimes conflicts among each other. So in fact, the challenge is this: how we can get together and build consensus on all those things. Thank you.
Thank you, Prof. Titi. That would also mean that we need to anticipate what will come in, say, medical and health professions education in the future, and also how to, let's say, being on the same page, having the same agreement about what do we expect from, and how we define the quality, what are the indicators, and how we can make agreement on that. And we also have a question in the chat box from Professor Young. Thank you. Prof. Titi, thank you very much for the thought-provoking sharing. What can perhaps universities do to get the accreditation of its medical programs to be transformative and exceptional?
Yeah, these are two opposing situation. In fact, when we want to be transformative, it means we want to ensure that every student has a chance to develop their talents. So learning becomes individualized, and we need to accommodate those individual talents, and we need to ensure that every student has the opportunity. We don't see them as a mass production. It's more like a craft, individual craft. In fact, outcome-based education has those kind of characteristic, that is individualized learning and making sure that every individual has the opportunity to develop their own talents. And therefore, in outcome-based education, the curriculums follow the students. Is in the old curriculum, in the old content-based curriculum, the students follow the defined set of curriculum. So it's the other way around. In exceptional, the university try to become distinctive. So they want, for example, they develop a special themes for research, and they want to be strong in those research. So they only focus on accepting students with specific talents according to their main themes that they want to develop. So yeah, I mean, university can choose which perspective they want, and also the government or the accreditation agencies can choose which perspective they want to use to define quality. But if we want all four together happening at the same time, that is not rational. That is difficult. Yeah. Okay, so I hope it answered your questions. Thank you, Professor Young.
Thank you, Prof. Titi. And there's another question from Dr. Hikma. It's so interesting, but then how does, in our context, the relationship between the healthcare system and our educational system, where are both system structures founding, and is there any study which already explored both system perspective on 4 components of quality? Seems like a tough question. Please, Prof. Titi.
Yeah. Yeah, they are in higher education, in many quality assurance systems, especially for higher education, they tend to use the perspective from fitness for purpose. Therefore, they use indicators like to what extent the graduates fulfill the needs of their stakeholders, something like that. In terms of research, I haven't yet come across a lot about that. Maybe there are many research on that, but I haven't yet had read about those research. And health education, health profession education, medical education is strongly linked with healthcare system. It is very obvious that we cannot produce physicians or specialists without their involvement or putting them in the hospitals or in the community health centers. And the other way around, the hospitals or it is difficult for especially many hospitals who are involved in delivering teaching learning process without the involvement of a medical school or health profession education school, because we want to produce physicians that are compatible with our healthcare system, and healthcare system is contextual. Between countries they are different, and also between different provinces they may also be different. So the question is, can we produce a medical graduate who can practice anywhere in the world, or we need to contextualize our graduates according to the best compatibility with the needs of their country or the needs of their community. I hope this answers your question. Thank you.
Thank you very much, Prof. In the different healthcare system will also have different expectation and different standard, and that would also, to some extent, affect how medical schools define their education system, and also the accreditation system define their standards. Okay, any other questions from the participants? You can raise your hand and also give comments through the chat box. Following to different standards and also different expectation, different, let's say, agreements between the stakeholders, Prof. Titi. As you can see that maybe some of the medical schools already have a very established systems. They have a very strong quality and the best practices in their medical education. But the other schools might only just started, or they have struggled throughout the years that they've been established. So do you think there should be a different standard or different indicators to determine, okay, then this means you meet the expected quality, or you don't meet the expected quality, so you should do this kind of things. So how would the regulators actually, how to behave or how to make decisions for the different quality of medical schools?
Yeah. So again, we can choose to have one fits for all, one standard for all, and every school is judged against those standards. Or we may choose to that a medical school is judged according to their own vision mission. You get my point? So in the first option, we have one standard for all, yeah, where each medical school must meet those standards. Or we can have another option, that is, we don't have one standard for all, but we individualize. We look at each medical school based on their vision and mission, based on their endeavor, their attempt, their programs to achieve those vision and mission, for example. Yeah. And if they are consistent, if they are showing commitment, consistency, and also progress to achieving their goals, then it means they have quality education. The goals can be different. The vision and mission are different among universities, among medical schools. Yeah, so this is two different approaches. And the trend now in because those factors are not under their control. For example, say about criteria in human resources. We know that, for example, a medical school, we set standard, yeah. Each medical school must have, say, 30 or 40 medical teachers with such qualification. This is, we set the standard for all. There are medical schools who cannot meet those standards, not because of they don't want, because to be able to recruit the medical teachers, they depend on the budget. It's maybe a public university, or it's maybe a medical school supported by local government, and there is a changes in governor, etc. So it's complex. So not every aspects can be controlled by medical schools or university. So is it fair if we assess them or give them, in bracket, punish them for the things that they cannot control? Yeah. So we need to consider about this. Thank you.
Thank you very much, Prof. Titi. That is indeed a perspective that perhaps not all of the people who are involved in medical and health professions education are on the same page about that. And I think I would like to invite one or two last questions from the participants. Do you have any questions or comments?
Okay, just maybe while waiting. So that is the essence of complex adaptive system. That it involves a lot of stakeholders, it involves a lot of agents, and no one is as the chief commander of all these stakeholders. You know my point. And its agents or its components work independently, but they are interconnected. Like a medical school, they need to involve many teaching hospitals, many community health centers, also many villages. But they cannot control them. They cannot control. If one teaching hospital suddenly disconnect or suddenly end their MOU with the medical school, they're not in command or in control of making them stay with the medical school. Or if previously one teaching hospital is only used by one medical school, and then the owner of the teaching hospitals decide to also accept other students from other medical school, from other health profession education institution. So what can this medical school do? Of course, it will affect the process, the teaching learning process. But yeah, so this is why medical school, health profession education institutions are working under complex adaptive systems. Thank you.
Thank you very much, Prof. Titi. And it is indeed, we are currently needing something that keep our mind to keep adapting to the changes and maybe disruption that we already experienced before with the pandemic, and how our not only healthcare system, education system, but how the accreditation itself will perhaps need to be changed and need to be adaptive for the upcoming challenges. And thank you very much, Prof. Titi, for sharing your expertise. And I think this will also mark how you present. I think this is a very insightful topic that you will perhaps also present it tomorrow in your inauguration. And I think the last comment from Dr. Riani Wikaningrum, can I conclude that accreditation is a public, social, and professional accountability of its institutions? Would you like to respond to the comment, Prof. Titi?
Yeah, that is one perspective. If a university chose to define their quality as being accountable, it's okay. It's okay. It's a choice. Yeah. But maybe another university chose to be excellent. They want to have distinction. They want to have internationally recognized, for example, rather than, more accountability towards their people. Now we know that many universities are pushed to be world-class university, international universities. Are they really solving the health problems of the community in the area or not? Yeah, so which one? So it's again, it's a matter of choice, and whatever we choose, I think the next speakers will also give the perspective of how to choose among those perspectives, whether you want to choose accountability perspective or fitness for purpose perspective. It's again, it's different way of looking at quality. It's not a matter of right or wrong. Yeah, in the social construct, there is no right or wrong, but it's our choice. Whether we choose which one we will choose, again, it's a matter of choice, but this choice should be agreed by all stakeholders. That's the point. Thank you.
Thank you very much, Prof. Titi, for the presentation. Any other comments or last comments from our participants? Okay, yeah, while we're waiting for our next speakers, I think I would like to invite perhaps Dr. Yoyo to give comments as the Friendship Directors. And since we are empowering our fellows for the change agent and also our alumni, Dr. Yoyo, are you still with us? Dr. Yoyo perhaps can share his comments about how the friendship or perhaps FAMER fellows, what they can do in order to support how to make the accreditation system actually as a catalyst for improvement and changes for the better in the medical education institution. Dr. Yoyo, are you with us?
Yeah. Sorry, I cannot web on I cannot on cam. Yeah. If all of you want to explore more, want to like what's from the challenge for us about maybe we can take some point of view on accreditation, you can do in your project and propose to us to join with us in friendship, and then during 2 years we can explore together with us with the faculty of the friendship, and then we will discuss with a lot of expert on your project. So please, if you have any idea, if you want to prove something on accreditation, if you want to improve your accreditation in your institution, don't be hesitant. Just write down the proposal and then send to us and join with us. In friendship, you will meet a lot of experts, include of course Professor Titi. So you can get advice, you can discuss with her, and we can discuss also with others expert how we improve our institution, or how we develop some topics, some aspect of the accreditation in your health institution. I think that's all for me, Ram.
Thank you very much, Dr. Yoyo. And this also, I think this perspective is not also applied to Indonesian context, but also other countries in Southeast Asia and also Asia and perhaps across the world, that how we can start the changes from something small for our fellows or our MHPE alumni and for other educators around the world, that we can change for the better. We can start the changes and we can see how the accreditation system in our country and how we can use the input from the result of accreditation to improve our educational practice. I think we're still waiting for Prof. Genevieve to start. Can we show the CV for the Prof. Genevieve? Thank you very much, Prof. Titi and Dr. Yoyo, for the comments. Yes, Professor Dr. Genevieve Monu is an MD graduate of the University of Ottawa and completed her pediatric residency at the University of Toronto Hospital for Sick Children. She is a professor in the Department of Pediatrics and Emergency Medicine at the University of Ottawa and practices pediatric emergency medicine at the Children's Hospital of Eastern Ontario. In January 2023, Dr. Genevieve Monu became Vice President of the World Federation for Medical Education, or WFME, and also appointed as Chief Medical Workforce Advisor for the Government of Canada's Ministry of Health, Health Canada, in August 2023, in support of the efforts to address the health workforce crisis. On June 30, 2023, Dr. Monu completed a 10-year term as President and the CEO of the Association of Faculties of Medicine of Canada, AFMC. During her tenure, Dr. Monu was instrumental in shaping and delivering on AFMC's key priorities. She was the secretary to the Committee on Accreditation of Canadian Medical Schools and the Committee on Accreditation for Continuing Medical Education from 2011 to 2014. Dr. Genevieve Monu, I think she's not here yet. So can we move on to the next slides? So I will introduce all of the speakers here who already joined us. And the next is Professor Charles Bullet, is a medical doctor from University of Liège, Belgium in 1966, and he specialized in public health from Université de Montréal, Canada, epidemiology from McGill University, Montreal, health system management from Harvard and Stanford, USA, and education of health professionals from Université de Paris, Tutine, France. As staff member of the World Health Organization for 30 years, he initiated several health workforce policies and projects in collaboration with ministries of health and of higher education, professional associations, and health professions educational institutions worldwide. He is best known for his work on social accountability of academic institutions, primary health workers, the WHO strategy towards unity for health. Currently, he is an international consultant and president of the REFRES, the International Francophone Network for Social Accountability in Health. You can check also the website, www.refresh.org. And we already have here Prof. Genevieve Monu and Professor Charles Bullet. Prof. Genevieve will start her presentation after this and will be continued by Professor Bullet. So it is a continuing two presentation, and I will invite questions for discussions after both speakers. Prof. Genevieve, I think it's will be the first to present, and after that, Professor Charles Bullet will present his presentation. Thank you. Prof. Genevieve, I think you're still on mute.
Oh, thank you. Can you hear me?
Yes.
Fantastic. Thank you. And now I'm going to try to share my slides and we'll see how that works. I will just need a moment here to see if I can make this happen. It's been a little bit of a challenge. Let's see. Are you able to see my slides here?
Yes, it just needs to be on slideshow.
Okay, perfect. And how's that?
Yes, great.
Thank you
Thank
so
you.
much. It's such a pleasure to be speaking today with you. Well, today for you, for me, it's yesterday evening. It's Sunday evening, and in honor of Professor Titi, who has become such an important colleague and friend for me as the Vice President of the World Federation for Medical Education. So just to start with an introductory slide to let you know a little bit more about me. So yes, I practice pediatric emergency medicine in Ottawa, Canada. And as you can see on the slide here, I continue to have to wear PPE to protect myself when I'm examining patients, which is always a challenge when you're dealing with small children, but that is our reality now. You see the Canada flag there because one of my positions now since August of 2023 is as a representative of the Government of Canada, working with our Federal Ministry of Health as the Chief Medical Workforce Advisor for Health Canada. So helping our government determine how to best manage our health workforce crisis in Canada, as most countries are experiencing across the world. And one last slide over on the right are my grandchildren. I have 6 beautiful grandchildren who are really my raison d'être, who are the reason why I do what I do. And I think it's really important for each of us to remind ourselves what our purpose is. And my purpose is to leave the world a better place for my grandchildren. So I'll move on to the next slide. So although I've been asked to present as the Vice President for the World Federation of Medical Education, one of my recent previous roles has been with the Association of Faculties of Medicine of Canada, so a national leadership role in Canada, and which I held for the last 10 years. And while I was in that role, I had the opportunity of working very closely with our leaders in our medical schools, our medical students. And one of the pieces of work that they did was related to the topic at hand this morning for you, which is planetary health. And I'll just take a little step back to really introduce the topic of planetary health. And I think for everyone listening today, it will not be a surprise to any of you that the issue of planetary health and the issue of the climate crisis is really one that has been deemed by many leaders and many important publications such as Lancet as the most important crisis, the most important health issue for us in this generation. And so I will not need to explain to you, the specific details of that, about how planetary health actually affects the health of individuals. It affects entire regions, whether it's because of the issues in the increased heat in regions. So whether that's related to fires that require us to completely evacuate regions, which is something that in Canada we've been dealing with over the last several months, whether it relates to flooding in other areas. And there's not a single region in the world that has not been affected by this climate crisis, and really calling us, each and every one of us, to consider how we can, as individuals who are involved with education of the health professions, address this issue. And I think, we really have to realize that each and every one of us needs to do our part to address this. So in Canada, the first part of my story is one that involves our medical students. And I don't know what it's like where each and every one of you come from, but in my environment, you know, if you bring medical students in the room, they usually have the best ideas. And so our medical students in Canada actually, you know, years ago came up with a specific curriculum for medical students related to the need to ensure that, you know, every single medical student really understands the impact of the climate crisis on their future patients and on the health system and on the planet. And so what they did is they actually created an evidence-based framework related to planetary health and established some competencies that they felt needed to be brought to, you know, to all medical students across the country. And so they established 11 competencies that were focused on 3 foundational domains. So the first is advancing planetary health justice. And so there are many aspects to this, which include the fact that, you know, as our planet continues to suffer through this climate crisis, that it actually continues to accentuate the divide between those groups who seem to be privileged versus those groups who are equity deserving groups, and those groups that are needing to be really highlighted as having particular needs in health. The second main domain was managing and preventing health impacts. So again, the whole focus here on prevention and understanding that not only do we have to deal with what we're you know, what we're faced with at this moment, but really understand how we need to be part of the solution, part of preventing future impacts. And thirdly, leading, collaborating on mitigation and adaptation. And, you know, all of this also includes circumstances around working with the health system and the health system players and trying to really reduce the impact that the health system has actually on planetary health. And so I'll move to the next slide. So our students created this incredible curriculum that was competency-based, and this was brought to our our deans of medicine. And so in Canada, we have an association that brings together the 17 medical schools, the deans of the 17 medical schools in Canada. This is the Association of Faculties of Medicine of Canada. And when this curriculum was brought to the board through our Standing Committee on Education and a specific working group on planetary health, the curriculum that had been created by the students was actually entirely endorsed. And so, you know, what that means in our environment is that if all the deans of medicine say that in fact the this particular curriculum is endorsed, this basically means that, you know, every medical school will actually be providing this curriculum. And so, you know, how this gets implemented specifically in each school may vary somewhat, but at the end of the day, this does mean that our students were able to really significantly impact their own training by bringing forth this curriculum that then was endorsed by the deans. And so in the next few years, this was endorsed in the fall of 2022. And so we expect, you know, this to be implemented over the next couple of years, and is really an outstanding example of that that student or learner leadership and the positive effect that it may have. So oops, I think I skipped. I'm going to go back. So, with this in mind, the deans of medicine and myself at the time when I was president and CEO of the Association of Faculties of Medicine, really started thinking about, what else we need to be doing as a country to ensure that we are doing everything in our power, everything in our realm of influence to move forward on the issue of planetary health. And so the idea came about to, in fact, develop a declaration on planetary health that addresses the role of academic health institutions, so medical schools, nursing schools, schools that relate to any other health profession, and what our role is or should be in addressing planetary health. And so this was done in advance of the international meeting that we were holding for the first time, our inaugural International Congress on Academic Medicine. And what we did is we brought together experts from around the world in planetary health and asked them to help us craft a declaration that speaks to the issues of planetary health and what the role of our institutions should be. And so that led to the creation of the Academic Health Institutions Declaration on Planetary Health, and really clearly stated the fact that we believe that the health of the planet is a code red emergency, and that we call for the immediate implementation of planetary health education and research, and the transition to a climate resilient, low carbon health system in order to build a healthy, sustainable, and just future for all. So what that means is that we are really asking our academic health institutions, so our faculties of medicine, of nursing, of all the other health professions, the universities that house these faculties. And depending on which country you come from, the relationship that these institutions have with the academic hospitals and the health system in general, really calling for the institutions to really do what it needs to do to address not only the education of medical students, which you just saw an example of, but the education across the continuum of medical school, postgraduate education, continuing education, also looking at the realm of health research and the focus that health research should have on addressing the climate emergency, as well as the influence that these institutions can have on the health system, and ensuring that, for example, operating rooms look at opportunities to reduce waste in their functioning, and also looking at how the institutions themselves, the faculties and the universities, look at moving towards net zero waste, look at no longer being supportive of fossil fuel, etc. And so this declaration was launched in April of 2023 at our International Congress on Academic Medicine. We had some great supporting comments from the World Health Organization and their branch. This declaration was endorsed by the Planetary Health Alliance, which is an international group who are engaged in development and very, very supportive. At this point, we have almost 500 signatories to the declaration, and that number continues to climb. And when I last wrote this slide, it was that there was a Lancet commentary submitted in advance of the Health Day of the COP28 meeting in UAE starting later this month. And in fact, that commentary has now been published. And so we're very pleased to be able to spread the news around the declaration through the Lancet publication. And so as you'll see here on the left-hand side of the slide, really what the declaration does is that it asks the the academic health institutions to take the planetary health pledge to ensure that there is an appropriate framework around planetary health education. So you saw an example of that from our Canadian student organization. And endorse the fossil fuel non-proliferation treaty, which is a hard one, which means you will not be investing as an institution in fossil fuels. And for some of our institutions in Canada, that was actually a very difficult ask, but they have moved forward with this. And again, as institutions looking at a net zero emissions goal for 2024, and then looking at ensuring that healthcare professionals and learners value evidence-based training to reduce overdiagnosis and necessary investigations and treatment. Ensure that research policy and advocacy on planetary health is firmly recognized, and that fiscal resources are allocated to do this research. And so, again, those are some of the areas that I previously mentioned. And to themselves reduce emissions associated with travel, as well as offset travel-related greenhouse gas emissions. And so we know that many conferences have actually been set up in that way. And become an anchor institution of sustainability to actually, sort of be leaders in their region and support others to actually join in, and look at local agriculture programs, zero carbon energy production, and circular economy practices. And so lots of opportunities. And again, we know that our universities and our faculties are leaders, and this is in fact how we can actually make a significant difference. And so, sorry, there was one last slide. Let me see if I can get back to it. And again, I'm having trouble displaying some of the pictures, but hopefully you see at the bottom of the slide. Let me just see if I can get the picture. No, it won't go. Having problems with the Google, but there should be at the bottom of this slide, you should see a link that actually links to the declaration that is on the site of the Association of Faculties of Medicine. And here you will be able to find the declaration itself. And you will be able to find the site that allows you to become a signatory. And so you can become a signatory as an individual, as well as a faculty or an institution, or you can become a signatory as an organization. And so many opportunities to declare your support for this activity. And as you heard, this is something that is currently of great interest to Lancet. This is something that will be brought forth to the COP28 conference, the climate change conference supported by the United Nations that's taking place in the UAE. At the end of November and throughout the first week of December. And so really an important movement that we hope you will all engage in. And again, I'm very thankful to Titi and to the organizers of this event for inviting me to speak about this important topic. And so thank you very, very much. I'm happy to answer any questions. And I will stop sharing.
Thank you. Thank you, Prof. Genevieve, for the insightful presentations. I think it's something new for lots of us, since it is a very it's an emergent and important and urgent topic that perhaps most of us are not aware of. And I've already shared the link in the chat box. So if any one of you would like to see about the initiatives, the Planetary Health Declaration, you can click on the link. And you can also ask your questions through the chat. While we are moving to the next presenter, I would like to invite Professor Charles Bullen for the next presenter. And after Prof. Bullen's presentation, we'll have the discussion. So I hope that Prof. Genevieve will stay in the Zoom meeting. Thank you. Professor Charles Bullen, are you with us? Yes, thank you very much. I would like to invite you to start the presentation. Thank you, Mr. Charles.
Well, thank you and good morning. I am speaking from the Geneva area in Switzerland. It's 3:30 in the morning, right? So I hope you can hear me well.
Yes, your voice is
And
clear.
I hope you can pass my slides
Yes.
from your end.
Yeah.
First of all, I want to congratulate Titi Savitri for her inauguration. It's a wonderful achievement, and I'll like to pay my respect to Gajah Mada University, which a university that I have visited years ago, and I think the first time was maybe 25 years ago. And I must say that the deans of the medical school at that time had already expressed interest in social accountability of medical school. So it's one of the first universities that had requested WHO to pay a visit and discuss with the university leadership on that particular question. So it's a pleasure for me to be here. And if can I have my first slide, please. All right, so what I wanted to say as we are starting with this presentation is for us to be aware about the global context that we are living in. My next slide. I think we have to be aware about the challenges that we have to make our world of sustainable peace and social justice. And I think this is an incredibly important challenge for all of us. And I think for all of us, from a personal point of view, for our profession, for our institution, for our country, and for our planet, as just Genevieve Moineau mentioned. And I think it is important for a medical school, an academic institution, to understand and accept the fact that I have a particular role in contributing to meeting those challenges, because they are preparing a future generation of leaders in the health system. They are also conducting research, and therefore they are able in a position to ask relevant questions and come up with answers. And then they have the mission also of providing services. And by providing services, they can serve as a model to the health system in general. So I like to put that picture in the front, because all what I will say is connected with that. Now the subject in my next, please. What is a socially accountable medical school? Now, there is a definition given by the World Health Organization some time ago, almost 3 decades. And I like to recall that because it has been used as a reference in many publications worthwhile. There are 2 sentences. The first one and I'm highlighting the important terms, it's an obligation. I'm saying that because in many enterprises, for instance, it is an option to be a socially accountable, but we take it as an obligation from the World Health Organization to direct education, research, and service activity towards addressing the priority health concerns. All right, the priority health concern. Another important term. So we're not talking just about medical care. We're talking about health and all the influences of the determinants of health that we may imagine. And again, our purpose is to serve. So we have a mandate to serve. We're not serving ourselves. We're serving others, right? And the second sentence is important because those priority health concerns are not just defined by the academic institution, the medical school. That would be too easy. They are defined jointly by those stakeholders, as we call them. The government, of course, the healthcare organization, the professions, and the public, civil society. So that is the background. And of course, as we are talking about the stakeholders, I'd like to have the next slide, please. Now we call that the partnership pentagram, and we like to identify 5 key stakeholders in any health system. That's why we call it a pentagram. And we are only one among the several. And as I've heard Titi also saying, we're not necessarily the most important one. And we are not necessarily the ones who can have the greatest influence on the health system. So we're aware of that. And not only is a medical school the only academic institution, and as we call about planetary health, we need faculties of economics, of social sciences, of management, of education, of arts, what have you, to be equal involved. So it's important that we understand that we're only part of a very complex system. But this picture also is inviting us to have all those interaction, connection with all of the stakeholders. And in the center is the health needs of society. That's something that must unite us. And I heard, I think Titi saying it is not easy to have the different stakeholders being united. That's true. But one way to have them united is to ask them the question, do you agree that your essential mission is to serve society? And by serving society, we have to be much more explicit. And I think listing the key values for which we are working, and which is our raison d'être, which are those key values, because it's the value system that unites people, a nation, and the planet, right? Now, social justice is one. Now, providing equity and good care to every citizen in the world is one. Another one is patient-centered care. We consider a patient in its complexity, and not just an organ that is temporarily sick, a person in its living context. That's another value. Another value is the relevance to the context. Now, health is influenced by so many other actors, political, cultural, social, economic, environmental. So it is for us to understand that and not just being locked down to the medical sciences aspect. And another value is certainly to make sure that the health system is sustainable, because we need to make an optimal use of the resources, right? So now, if we all went to agree on those 4 values, then we begin to work in the direction of a more cohesive, coherent health system. All right. Now, having said that, let me give you another reference. Next slide, please. Again, in the definition of social accountability, this is the cover page of an important document. I'm sorry if one of the titles in Spanish, but it shows you that this document has been translated in several languages. It is the document that outlines the global consensus for social accountability medical school. Because, as I mentioned in the definition of the WHO, which now dates back almost 3 decades ago, it was important to ensure that the ideas that were promoted years ago were meaningful to the rest of the world, and not just, I would say, the ideas of a few pioneers' minds. And so we got this global consensus as a result of a Delphi study conducted by more than 100 experts throughout the world. And we know the complexity and the rigorous approach of the Delphi study. And so this is a document that outlines 10 strategic directions for a medical school to become socially accountable. And I would certainly warmly recommend that you have that document on your desk or close to you on the shelf to be used as an inspiration. Now, let's be more pragmatic. The next slide, please. Now, the next slide is, how do we recognize a socially accountable school? What should it do that we can see, recognize? Well, 3 elements. First of all, it is an institution that responds to present and future priority health needs of society. All right. It's a simple phrase, but we're talking about future. We're anticipating what society will be, how the world will change. And we know that we are, as we say, in the middle of winds of change for so many reasons: demographic, political, resource mind, etc. So the medical school has to anticipate what a health system might be in the future, what the challenges are, so that we can meet the value that I was mentioning. This is not an easy task. And it would be wonderful if each school, for instance, had close to the dean's office or close to the faculty council office an office of social accountability, so that it is a sort of intelligent, a brain that helps an institution to anticipate and identify what the future priority health needs and the current priority health needs are. Second, and I think Titi mentioned that once we are aware about those needs, we have to do something about it. And so we transform our education, research, and service mission accordingly. This is not an easy task because it may induce dramatic changes in the way we practice in a medical school. And not only in the curriculum, I would say, if I may use that term, it's probably the most easy mission of a medical school, because, we control it easily and we can change the curriculum, although it has its own challenges, I know. But it's transforming research as well. Are we asking the right questions? Are we putting the money on the right items when we consider research? There are a lot of evidence that the majority of research grants go to biomedical research and very few to psychosocial aspect of health. And of course, the service mission. Now, the service mission, and again, we have to be clear about that. It's not having the latest tertiary hospital, which is a good thing to have, of course, but it's also to consider the primary health care is the solid foundation of any efficient and equitable health system. So it should be a priority for any medical school, because that's where we can make the greatest possible difference on the health status of people. And the third area is certainly working with others, partners with other stakeholders. And I heard Titi say that, well, of course, the medical school cannot be held responsible for the things it has no control over. Of course. But I think we have to be cautious with that sentence, because we know many medical schools that go beyond their usual mission and limits of responsibility. For instance, if I were a medical school, I would be very proud of my graduates, whom I have trained to acquire the best possible competences. But I'm so proud of them that I'm interested to know where they are going to practice, what specialty they are choosing, how they will be motivated to work with others. And that is a responsibility that a medical school can share with others. It can share with policymakers. It can share with professional associations. It can share with society. But the majority of medical schools are not prepared to walk outside of their traditional boundaries. And if you want to be social accountability, you have to take that risk to go a little bit outside of your traditional boundaries, so that you follow whatever you have done. You follow your graduates, you follow your research, and you follow your service, and see whether it is making a difference. And I'm coming to my fourth point, and that is evaluation and accreditation. And we use that to assess impact on society. Now, impact on society is only possible for a medical school if it works in close partnership with other stakeholders. Now, I cannot be asking the medical school to ensure that everybody has equal access to healthcare, because it's not my main responsibility. But I think that I can share a responsibility in that. I can share it by working with others. But again, it means a transformation of my philosophy of an academic institution. It is not working in a tower. It has to be connected with society. If I can have my next slide, please. Well, let us ask those simple questions to ourselves. What is accreditation? Well, in a nutshell, it is obtaining credit, right? Credit. Now, if you go to the bank and you ask some loan for building your house, so you're asking a credit, you will receive that credit at certain conditions, right? And so what sort of conditions? So what for? It is because you are recognized as practicing an excellent work. And again, we ask, what is excellence? Well, excellence is to make the greatest possible impact on people's health. Now, a medical school has impact on the health of people, and that's the question that was asked at a global consensus, the document that I showed before. Can we do better? Can we do more than that? Can we use our potential in a more practical way to have the greatest possible impact? And that's true. That's something that we have to consider. And there is a lot of way to go for medical school if they want to be impactful in society. And I mentioned the condition to do that. Now, I must recognize that this definition of excellence is not usual. And I'm referring to the university ranking of the world ranking of medical schools and universities. If you go to the Times ranking system, to the Shanghai Times ranking system, there is little about having an impact on people's health. There is reference of, do I have a Nobel Prize in my school? Or do I have a lot of people with having received awards in their clinical research practice? Do we have many publications in peer-reviewed journal from our universities? Those are the main criteria, right? And so we are forgetting probably the most important, which is the umbrella under which all the other indicators are coming. And that's the impact on people's health. And I think it's important that we don't forget that. Otherwise, we are losing our soul. And we are losing what I mentioned in my first slide, in the winds of change. We are all responsible for ensuring sustainable peace and social justice. So that's what we have to do. And all the rest comes underneath. Now, on the question of excellence, my next slide, please. Now, this is a publication that appeared in the journal Education for Health. And it is called Accrediting Excellence for Medical School Impact on Population Health, just what we mentioned. And now, this paper was co-authored by about 70 international experts in the world, belonging to 50 different countries and international organizations. Recognize that it is impact on population health that should be accredited as excellence. Now, I'm pleased to say that Geneviève Moineau was one of the co-signatories in her capacity of president of the Association of Faculty of Medicine in Canada. And what is the main message of that paper? There is a need to re-examine accreditation standards and processes currently used worldwide to better respond to current and future priority needs. And I must confess that the major accreditation mechanism used in the world pay poor recognition to that essential indicators make an impact on health and therefore being more socially accountable. So that is the task we had in front of us, is to reviewing those accreditation standards. In the light of that paper was put together a wonderful group, and I'd like to have the next slide, please. And that group is called the International Social Accountability in Accreditation Think Tank. And again, I must pay tribute to my dear friend Geneviève Moineau, who in her capacity at the Association of Faculty of Medicine supported that initiative, which is now coming to fruition. And I must also say that Titi was part of that think tank. And actually, she was part of one of the working groups working on standard setting within that international think tank. Now, in front of us, we have a part of that document produced by the standard setting group. And I want you to concentrate only on box 1 and box 2. Very simple. In box 1, we're saying what is needed for a society to be healthy. What are the initiatives? What are the policy? What are the programs? What are the action? So it has to do with priority setting. It has to do with health service delivery. It has to do with health workforce, etc. In the second box, that is us. That is a medical school that has a number of functions, a number of structural approaches. And so the invitation is to respond to that question: to what extent does my medical school respond to health and society? And we take each of the elements of the medical school. Now, in that box 9, there are 9 elements. There might be more, there might be less. And it's not just the mission of education, research, and service, also the governance of the medical school. And so we ask the question, for those important elements of health and society, are we contributing? Can we contribute better than what we do? So that's the key issue that future accreditation system will be invited to reply. Now, the next slide, please. Now let's concentrate to the box number 3, because accreditation is to agree on standards, right? Now, in this particular conceptual framework, there is provision for a graduation of social accountability from 1, 2, and 3. And it is true. This is not a question that receives the answer yes or no. It's not a binary situation. There is a graduation, because any medical school in the world fulfills some sort of social obligation by the simple fact that it does exist. But there are gradients of social accountability in the way we defined it before. Now, grade number 1, so we collect evidence that a school is aware about the priority health needs of society. It is aware, that means it can list them, it's being discussed about, there are conferences about that, there are some teaching about that. So they're not ignorant about the context. They are fully aware. They do understand. But that's, I would say, an intellectual exercise, which is important, but that's an intellectual exercise. Now, the number 2, we are so convinced and so aware. And again, I come back to my picture with the winds of change. We are so motivated by that because we do understand in which world we are living, that we're making important transformation in our education, in our research, in our service. And again, I want to warn our colleagues not to be obsessed by just education, because changing a curriculum doesn't make a difference. What will make a difference of a health profession, in addition to education and have acquired competences, is the market, are the opportunity in society for us to practice what we have learned. Of course, we will practice all the technical aspect, how to better repair a bone, how to better operate on a heart. That's not a problem. That will be integrated in our practice. We are talking about the other things. Are we meeting the needs of the people? in their complexity. Now, even if we are educated on that, if there are no job opportunities to practice that, for us to work in teams, for us to be aware about public health problems, etc., it will not happen. So it is important that we understand social accountability as a policy for the whole academic institution. And it's not enough to say, oh, yes, I have a community-based activity for my student. No, that's just a little aspect. No, it is the whole institution that has to understand what the challenges are. It starts with the president of the university, with the dean of the university, with the faculty council, with each head department, and not just the public health or primary health care or community health department. You see what I mean? It is larger than that. And that is the issue. Now, the number 3 assessment goes beyond that. And that's the highest, I would say, degree of social accountability. You are concerned that what you have transformed makes a difference. And again, here comes the question. Is that the responsibility of a medical school to do that? I'm saying yes, there is a part of responsibility. And you have that responsibility if you can share with the other stakeholders. I'm just taking the example of where are my graduates practicing? Are they all practicing in neurosciences in the capital city? Or are they practicing primary healthcare in the remote villages? You see what I mean? Now, on this, which is a complex issue, of course, the medical school have a role to play by the model, by this philosophy being accepted by the whole institution that we are supposed to serve people. So, my colleagues, this is just a work in progress. And I'm glad that this international social accountability and accreditation think tank have produced that document that we hope to share with all accreditation worldwide, and to see how we can become a different agency that is progressive in understanding the challenges of our world. My next and last slide, please. Now, I know Gajah Mada, and I know what Indonesia has done in the area of accreditation decades ago, and it's probably one of the leading country in Asia that has taken that very seriously. And so I hope we and other colleagues in ceramic can work together and collaborate to face the winds of change, because they are coming. They're already there. And it is the the honor of an academic institution to be anticipating that in making the needed change. I put here a contact of a colleague whom can be contacted if we wanted to have more information. She is from Egypt. She has been the dean of a medical school in Ismaila University on the Suez Canal. She has been trained in education. She is part of the accreditation system in her country, in Egypt. And she has served as a consultant as many countries regarding accreditation. So, my dear friends, that would be the end. And I wish you all the best in your future activities. Many thanks.
Thank you very much, Professor Charles Bullen. I think this is something that we've been anticipating, and this has been there, the issue of including social accountability of medical schools as part of the accreditation indicators. There are some questions in the chat box for Professor Charles. Is social accountability the authority of institutions alone? Can, let's say, a medical practitioner implement planetary health as social accountability in daily practice? So is, I think, focusing on the output of medical schools, whether medical practitioners can practice, let's say, planetary health or going green as part of their social accountability. Would you like to respond, Professor Charles?
Well, thank you for that question, because it is extremely important. Because it's so easy to do wonderful things within the walls of a medical school. But then, is this practical? And if I were a health professional, does that mean something to me? Now, I must say that the ones who understand that better among the medical profession are the family physician, right? But many others too. I know a lot of pediatricians. I know surgeons. I know endocrinologists who understand that they have to practice outside of their office. They have to understand the wider context in which they're working. And I'm glad to say that my last conversation with the president of WONCA, and you know WONCA is the World Organization of Family Doctors, and I was sharing one of the last slides with her and saying, do you think all right. And I was sharing my last slide with the president of the WONCA, and she said, this is something we should apply to the medical profession. And so we understand how complex that is to change the mind of doctors. And I must confess that, well, depending on the countries, but there are many national medical associations that are very conservative, that they protect their own interests, their own views, and are not necessarily open to understand what are the challenges outside of their own interests. See, but that is human. That is human. We all behave like that. And so what I'm meaning to say is this: we need a strong cultural revolution for us to understand where we're going and what we need to do. It will take time, but it will come.
Thank you very much, Professor Bullen. And there's another question from the participant. When we want to implement or deliver social accountability in medical schools in our curriculum, for example, how to address the issue in the managerial system, for example, the financial issues regarding the budget or any facilities that they need to improve, since, you know, in Indonesia, not all of the medical schools have the sufficient resources. What do you think of that?
Well, you know, having worked in the World Organization and still being very active globally speaking, let me just share an observation. The medical schools that are convinced that social accountability is the way to go, usually it is the dean that leads that moment. The dean of, you know, people with authority within the medical school. And I think I mentioned that before. But of course, our colleagues working in community health, community medicine, primary care, they are so open to all that. And that is okay. But that is just one department within a medical school. What about the Department of Surgery? What about the Department of Medicine? What about the Department of Basic Sciences? You see what I mean? And there is room for everyone. But it's usually the dean or the head of the institution that shows the lead. Not easy for him or for her. Not easy, because you know, it is opening to all kinds of transformation that may upset some people, saying, oh, I'm not used to that. So what is that? You know, I have already so many things to do. Why should I do that in addition? So as I say, it's a change of culture. But you know, I like to remind our colleagues that in Canada, and Geneviève Moineau has mentioned that, there are 17 medical schools, right? Now, each medical school has a department, an office of a vice dean of social accountability. Each medical school, a vice dean of medical. That means there is a position that has a strategic importance in the way the school is being developed. You see what I mean? So it's Canada. Now, if I had said that it is in Botswana, you may say, oh, well, that's a poor African country, who cares about it? No, talking about Canada, right? So we see that coming. And so that's my answer.
Thank you very much. So that depends on the context, but let's say role model, and let's say having champions, having the leaders to start all of that is also important. And there's a last question that was messaged to me directly. How about the institution who does not think about social accountability? Let's say as a regulator or as the peer institution, what should we do? Is there anything that we can do to empower other institutions to have the same thoughts about social accountability?
Well, one of the things one could do is to begin to list all those activities within a medical school that are already close to the principle of social accountability. List them so that we're not starting from scratch. We're doing nice things. It's a matter of extending, deepening, widening, and have it better understood by the whole academic community. But there are already nice things happening, and we have to highlight that. So you've seen in the gradation of the different levels of social accountability, there is a stage 1 and a stage 2 and 3. But many institutions are already on stage 1 and on 2. So let's list them. Let's list them. I'd like to say something too on the role models, because you see, I have seen that many colleagues, when they come to the age of retirement, and they may be professor of medicine, professor of surgery, they may be, in very clinically involved activities. Once they come to retirement, they're saying, oh, this is the thing to do. Oh, we should have done that before. Oh, how come we have not done that before? You see what I mean? So because they're sort of in a free speech situation, or they are sort of liberated from the traditional environment in which we work. And again, I'm not blaming. That's all human. If myself, I would be certainly in the same situation. But there are some champions in each medical school. There are some leaders. There are some pioneers. There are people that are thinking a little bit further down the road, you see? And they do exist. Let them talk. Let students express themselves, because students are sometimes a little bit ahead of professors and teachers. You see what I mean? We see that, depending on which country, that we see that. So there is hope. But the institution should be willing to experiment and listen.
Thank you very much, Professor Charles. It's also important to include those voices who are not only the teachers, but also outside, and also perhaps the users of our graduates. I would like to invite all the participants. Should you have any question, kindly raise your hands, or any other question through the chat box. Okay. Well, is there anyone? Okay. Thank you very much, Professor Charles, and also Professor Geneviève, who already left the Zoom chat. But I think from those both of presentation, we can conclude that there are things that we need to adapt in terms of our accreditation system and how we want to improve ourselves. So there are several indicators. I think it's very interesting to introduce the planetary health which perhaps may not be familiar to some of area or regions of the world. And social accountability, I think, in Indonesia now has been raised as an issue that medical schools need to be aware of. And it's also actually part of, let's say, international accreditation system. So hopefully this will also benefit not only the medical schools, but also the other stakeholders, especially the communities, the public, and also the users. Thank you very much, Professor Charles, for your sharing of expertise. Now we would like to continue our webinar that we already have here, Professor Thomas Chaco and also Professor Young. I would like to introduce both speakers here. Thank you very much for joining us. Professor Thomas Chaco was the founder and director of the PSG Famer Regional Institute that administers the two-year Famer Institute Fellowship Program for faculty in medical schools in the South Asia region. He was also the Secretary General of WFME, Southeast Asian Regional Association for Medical Education, or CRAME, for 6 years, and was the president of the Academy of Health Profession Educators in India during 2017. Professor Thomas Chaco is often invited to be Senate or academic committee members of various universities of repute in India as external expert in medical education, and to the WHO expert committees to recommend improvement in teaching of public health in the South Asia region. He has been working in a lot of areas interest, especially in health professions education, program evaluation, in curriculum planning, competency-based and community-based education, and also how to improve the standard of teaching and the medical education. Well, I think the last one that will make you amazed by his achievement is that he's been awarded the Lifetime Achievement in Medical Education Award in 2022 by MAU India, a national network of 25,000 health professions educators. That's amazing achievement, Professor Chaco, and I'm sure that he will be willing to share his expertise and his experience in accreditation system in India. And can we also introduce Professor Young Rafidah Rahman for her expertise? Professor Dr. Rafidah Abdul Rahman is the president of Western Pacific Association for Medical Education, or WPAME, and she's also a professor of the Faculty of Medicine at University of Cyberjaya, Malaysia. And now she's currently the chairperson, panel of assessor technical working group at the Malaysian Medical Council, and she will be willing to share her expertise after Professor Thomas Chaco's presentation about the accreditation system at the WPAME. And at first, I would like to introduce or let Professor Thomas Chaco to have his presentations ready. And thank you very much for both speakers to joining us today. And after both presentations, I would like to invite the participants to ask questions or give comments. The time screen is yours, Professor Thomas. Thank you. Excuse me, you are still on mute, Professor Thomas. Yes.
Okay. So is my presentation visible?
Yes, it is. You just need to put it on slideshow. Thank you.
Okay. Greetings from India and Sarami. I am indeed very happy to know that Titi Savitri, my dear friend, whom I have been knowing since more than 10 years as part of the Sarami Executive Committee. The logo of Cerami shown on the screen shows the almost 11 countries of the WHO Southeast Asia region and includes India, Indonesia, and other countries, Myanmar, Sri Lanka, Thailand, and all these countries have been trying to focus and put together the context and the problems in the region. And my talk, I've been invited to share the experiences of accreditation for medical schools in India. So it's been a long journey. And as you realize, India is a big country, almost we call it as Indian subcontinent. And to impress on you the hugeness of the enormity of the size of the country, let me present these facts. India, the country of India, population-wise constitutes 1/6 of humanity. So 1 in 6 of people in the world live in India. And compared to the whole of all the countries in Africa, Africa stretches from Mediterranean Sea to almost the South Pole, and such a huge continent. All the countries in Africa, India's population is more than all of them. Professor Boland talked about Canada. Canada is also a huge country, and having 17 medical schools. So compare that to India, which has 706 medical schools. And each year, 108,915 graduates come out. And so that shows the huge scope and the stake that accreditation of medical schools, the import of that has on the world's and the country's population. As we all know, in India, the health system is delivered through the system of primary health care, where at the population level, for every 30,000 population, we have a primary health center. And the quality of care of the people who are working at this community level, population level of specific population group of 30,000 depends on competent human resources. And the other issue is because of the enormity or the large number of medical schools opening up every year, it has almost become a political agenda of the politicians to have one medical school in their own constituency. And sometimes that leads to dilution in the quality. Moreover, in the context of the health force competency needs of the health system, sometimes there is a question about whether the graduates that come out, the huge number, are they job ready? So that is an area of concern. And also area of concern is the curriculum dictated by the health needs. I will give answer to these questions. And fortunately, India had curricular reforms, and we have moved on from discipline-based to a hybrid competency-focused curriculum, which is a kind of backward planning exercise to produce the Indian medical graduate with competencies needed to function at the primary care level. There is another concern from the quality point of view is the system of assessment. When we declare a graduate as pass or fail, are we testing the job readiness? Are they linked to competencies that the graduate is supposed to discharge the duties? So we need to be worried about that. we are making some progress. It's a work in progress, but we will be there soon. So accreditation system is a very important contributor to the quality of health professions education in India. And another reason or a concern is about international acceptance of an MBBS degree internationally. The fact that even in the developed countries like the USA, about 30% of the workforce of the doctors are of Indian origin. So there is quality output, but they insist, rightfully so, that they pass the qualifying examinations. That's because some of the students and the examination system in India, there is an examination, but mostly test knowledge. And the other concern is not all expected competencies are tested. And there is also another concern of the question of standard setting to declare a graduate as pass or fail. We have an arbitrary 50% marks as the cutoff for declaring pass and fail. And so there is scope for review of the examination pass-fail decision or the standard to be set, which has to be dynamic. And the accreditation system in India was done by the Medical Council of India, which is an elected body from amongst the members of the Indian Medical Association or the practicing doctors. Also, it includes representatives from the universities. The Medical Council of India, you can see so many medical colleges, but it was in addition to this burden with triple responsibilities, giving permission to open new colleges. It had amongst its job responsibilities providing recognition and accreditation, as well as the huge task of licensing those who come out and they are allowed to practice. And of course, it is mandatory for all medical colleges admitting medical students to get recognition. It's a must. Let us examine how robust is the Medical Council or the accreditation bodies by examining whether the graduates that come up or out fulfill all the inputs needed in terms of students' academic capabilities, minimum requirements at admission, the student-faculty ratio, the faculty, how capable they are in their teaching, whether there are adequate infrastructure and learning resources that are available for the students, and the type of curriculum. Another factor that influences quality are the processes that the students who are admitted go through. The teaching learning processes, the student assessment and feedback, student support and mentoring while they are learning, the educational environment itself, whether it is conducive and supportive, and to make a well-rounded graduate, co-curricular activities, humanities, and social service exposures, and then opportunities for leadership and the processes within the organization and its governance, and the support of and the institutions support for faculty development, and also the policy for rewards, as well as whether the system engages in constantly program evaluation periodically, the quality audit and the quality assurance system. And also what comes out, the outcomes, competent Indian medical graduate, the graduates' attitudes and values, the results in terms of how they are performing on the job, and whether they are actively, reflectively engaging in practice for continuing professional development. So after getting a license, they need to update themselves, and so the habit of engaging in reflective practice. So these are the processes that determine the quality. And so it was through a study done by me, and it is also well known. The National Medical Council, the NCI, mostly focused on inputs. How many, what is, whether there is a cutoff, there is a competitive examination for admissions, what is the proportion of students and faculty, and then the faculty capabilities, the infrastructure, how many beds per patient, per student, and the type of curriculum. So this was mainly the focus of the National Medical Commission, or the accreditation body. And we also in India have the NAC accreditation, which is optional, whereas NMC is mandatory for all organizations or teaching institutions to be registered. NAC is an optional organization or accreditation that certifies whether the institution has a proper ranking or relative ranking of these usually universities, so that it adds to their prestige and it attracts better quality students. And then also, if we compare the Medical Council in UK and the WFME as a recognition of accreditation agencies, the newer standard encompasses inputs, processes, as well as outcomes. So it's a more comprehensive one. And so it is important for policymakers to decide what actually needs to be measured so as to ensure or assure quality. And so on behalf of CERAMI, myself and my colleague who are executive committee members of CERAMI, we did and published these articles about the quality assurance system in India, so as to start some thinking amongst the decision makers about what exactly should we be measuring. And in one of my articles, I communicated the need for recognizing educational scholarship also besides discipline-based research for inclusion and measurement of the quality of education in India. So the accreditation process underwent change within the country, and it was in 2019 that the National Medical Commission Act was cleared by the Parliament. However, there was only change in name, and the same old Medical Council of India standards continued. Mostly it is inputs based, and the MCI minimum infrastructure was and the faculty qualifications were insisted upon as an indicator or necessity or indicator of assurance of quality. The quality and process standards did not exist in the standards that were published. is provision for site visit, external review, and assessor. And assessment outcome mostly was punitive, and the assessment also was surprise. The team from the National Medical Commission or the MCI used to suddenly surprise the organization. Of course, the organizations were supposed to do a self-assessment through the self-assessment formats, and they were supposed to comply the deficiencies. But as a result of the surprise inspection element, and for the fear of getting de-recognized, it was very hard on the faculty to take leave in long stretches, because absence on the inspection day was treated as not existing as a faculty at all. But as a result of various pressures, including the pressure from the students and organizations like ECFMG, and the graduates' need for getting international recognition, the NMC agreed and applied for WFME recognition. It is hoped that it will transition because of the requirements mentioned for WFME recognition, that the system and processes will move from inputs to processes, and also assessing the outcomes of the products. So that is the hope. Another silver lining that is there in the existing accreditation system is the realization by the National Medical Commission that no changes in the curriculum will be possible to implement unless there is a there is a empowerment of the faculty through orientation and other workshops, and advanced instructional and research skills through the advanced course in medical education. Any institution also requires leadership within the organization. Leadership under the new definition of academic leadership is leadership everywhere within the organization. And so it is not just the top leadership, but also leadership among faculty. And for that, we also have 4 FAMER regional institutions functioning from 2004 onwards. And we have a huge pool of FAMER fellows, and we have a network meeting directly in the form of national conferences in health professions in education every year. And there is an opportunity for experience sharing as well as sharing success stories. And so we are moving in the right direction. Quality also means the quality, whether it fits the purpose, but the quality of graduate that have been listed. And fortunately, it is a good exercise, and they have clearly defined who and what competencies should be there in the Indian medical graduate. So fitness of purpose, satisfying the needs of the community. And then whether they are competent to ensure patient safety, whether the competencies they are having also ensure patient safety. And quality as an excellence with the highest standards for global recognition, as well as being competent at the local, national level. So all these things, as well as the obvious need for producing primary care doctors. These are the things, and also the Lancet Commission emphasized rightly about the need to move from traditional model to the needs-driven model, and that has happened and is reflected in the curriculum that has been agreed and facilitated by the national accreditation system in India. And so health needs and competency outcomes, they have all been listed in the competency document that is available on the website. And we have the training reoriented so as to ensure that quality care is delivered through the outcome competencies achievement that is listed. It is unfortunately not much emphasis is still put on program evaluation, because we need to not only assure quality but strive for continuing quality improvement. And only through periodic program evaluation of the existing program of training, we not only assure quality, but also patient safety. And so as a result, bodies like the National Accreditation Agency recommends internal quality assurance cell. Every institution should have an internal quality assurance cell. And this clause, I'm hoping, will also be included in the National Medical Commission standards, which will be made explicit in that all medical schools need to be incorporating that as a requirement. There is also a case for external education expert to be incorporated, because only an external educational expert as mandated to be mandated by the accreditation body will make it available within the medical schools, so that this external educational expert, having faced similar challenges in their own institution, will bring into the local medical school an outsider's perspective to provide solutions to the local problems. That through cross-fertilization of ideas, dissemination of good practices, plus also review efforts that have been taken by the internal quality assurance cell and the readiness for accreditation. So these are important elements. These are in fact the part of the WHO guidelines for quality assurance in basic medical education. So what remains to be done, to summarize, we need to do certain things to ensure international recognition, that is broadening of standards from the present inputs and processes and products, which includes interviewing and finding information from the employers of the graduates to identify gaps in the curriculum, which then need to be addressed. The need to contextualize the standards from the broadly stated WFME standards to the local and national standards, and the need to strengthen continuing quality improvement, and having assessors who are knowledgeable of the educational processes and systems, so that they will be in a position to judge the quality of the processes and inputs that are happening within the institution. Currently in India, it is mostly assessment of the inputs, which any faculty can do. But for assessing the processes and the outputs and the outcomes of the graduates, there is necessity for the assessors who assess the accreditation process to be knowledgeable about various educational tools and systems so that they will be able to process and go through the information that is presented as evidence and come to a conclusion, as well as make practical recommendations. So these are my thoughts in brief, and I'm open to questions and clarification. Thank you.
Thank you very much, Professor Chaco, for sharing your thoughts. And I think there are many good practices from accreditation system in India. There are several questions here, but I would like is that okay to stay after Professor Young's presentation? So after that, we will have this discussion. I would like to invite Professor Young to have the presentation. Professor Young, would you like to present yourself? Is that okay
Hello.
by you? Yeah, hi.
Very good
It's
morning,
nice.
everyone. Hello,
Good
everyone.
morning.
And it's greeting from Malaysia. I'll try to put up my PowerPoint.
Okay, thank you.
Give me a second. This can be a little bit fiddly. Okay. Again, greetings to everyone. Thank you, Professor Rahma, for introducing me. When I was given this talk, of course, this is very interesting, very close to my heart. But of course, I was asking Prof Titi whether I've been given 3 hours or what. So the answer that was given to me is merely 30 minutes. Definitely, I have to have a disclaimer here. This is probably lesser than 30 minutes. That's one. And I'll be talking from the perspective of my knowledge and experiences of the 3 positions that I'm holding. Of course, there are more experiences, but definitely cannot be covered within this short duration of time. And the beauty of being the last speaker is what I would like to say has been said by other speakers. So I think I can go very, very fast. Right. This is the essence of what I'm going to share. I'll be introducing the Western Pacific region and the WPAME. Basically, the WPAME stands for the Western Pacific Association for Medical Education. I'll be going through briefly, actually very, very briefly, on a few notable practices in medical education, which also include basic and postgraduate medical education. So this is the challenge actually in this region, and of course, I believe everywhere else, including Indonesia and other parts of the world. We are now actually, I believe everyone has moved from talking only the basic medical training, but also the postgraduate. So probably there might be, or there should be another discussion on what do we do in the postgraduate medical training. Right, I'll be sharing a little bit of experiences as an accreditation coordinator in my country, as well as being accreditation assessor in my country, as well as a few countries which I've been invited as much as possible, and perhaps a few thoughts on the way forward. All right, so one, the Western Pacific region and the WPME, basically as what's been introduced by the previous speakers, this is what we're talking about. The Western Pacific region is a wide area, and I believe all of you can imagine the challenges that we have from Mongolia up to New Zealand and somewhere in between. And here I'm from, basically Malaysia. I'll be introducing about the WPME. This is basically, it's been long in the, established from 1988. Basically, this is an umbrella organization of National Association of Medical Education and Medical Colleges in the Western Pacific region. So we are being represented by the countries that I've indicated earlier. And basically, this is a regional association of the Federation for Medical Education. And WPME focuses on quality, management, organization, support and delivery of medical training. So I've highlighted the key role basically here, mainly quality, rather than the details of how medicine is taught. Basically medical, I have to clarify here, medical education, the basics of curricular design, teaching, learning, assessments are definitely the linchpin of activities when we want to talk about quality. And sometimes we do have an overlap between, do we want to talk about all these issues about curricular development, teaching, learning, assessment, etc., or do we talk about the management of the academic programs? All right, but anyway, the current focus by right, it should be on the quality and management of medical training. And last point here, we try to champion the application of the WFME standards for quality improvement, very specifically at the moment in basic medical education, because why it is quite uniformly established. Of course, we do have other standards, i.e. the postgraduate standards and so on and so forth, but probably there's those are again work in progress. And with the application of WFME standards for quality improvement, at least in the basic medical education, we have had numerous external evaluations of medical school program, and which I'm going to highlight the next slide. And this is been done, actually the last point there, promotion of national programs of accreditation mostly has been done, mostly are accomplished. Many thanks to my predecessors, but they also still work in progress. So basically, this is what we are in the region. I will share now notable some established practices in our region. As what I've indicated earlier, we have worked very hard over the many years, and I would proudly say that all the countries are represented in the WPME advisory board, despite our differences. And we're also proud that majority, up to now and counting, basically 11 countries with established accreditation system for its medical programs, be it for the basic medical program or for the postgraduate. And we're also proud to see that majority of the countries between the WPME system has gained the WFME recognition of their respective accrediting agency. This can be checked basically in the WFME website. All right, sharing again a few accomplishments. WPME participates in the global initiative of the WFME. Again here, for those who couldn't catch what WFME is the World Federation for Medical Education. And representative sits in the council of the WFME and its annual meeting. And up to now is usually the president who represent the WPME in the WFME. And currently that's what I'm doing as a president. And last, I would say accomplishment is that we do have, this is quite recently established, i.e. the last point there, advisory team within the WPME, that there's national consultations as well as external evaluation as again WFME global standards in the WPAME countries. Sharing a little bit more, we do have standards for postgraduate training in addition to the standards for undergraduate training. These are a few countries that has come out with the standards for postgraduate training. Probably again, this is food for thought for everyone. Probably this is where we need to move on. And this is again another interesting practice between our two country members, i.e. collaboration between medical councils in accreditation of basic and also vocational education. I would say here probably one of the advantage of this is sharing of resources, sharing of expertise, and probably this is one food for thoughts that can be taught for countries that have similarities, perhaps, right? It's not easy, but probably there's still some thoughts. But anyway, 2 of our countries have done that. Again, here, this is a bit tough. How do we address the interaction between the MBBS or MD degree, i.e. the basic undergraduate degrees, with the postgraduate qualification as well as research? This is one example of intercalated program, which combines the MBBS PhD or MD PhD, definitely with the strong research component there. Okay, last but okay, 2 more, basically legislation. I feel that this is uniform in most of the WPMA country, but again, they are one of 2 countries that's still learning how to formalize legislation or registration of its medical practitioners that are based from the accreditation processes. And this is one, to me, interesting observation. This is basically from Mongolia, where they have common educational standards and program criterion for all healthcare disciplines, or for all health discipline professions, i.e. be doctors, nurses, etc. Probably in the frontline profession, they use the same standards. This is again food for thought, where we talk about interprofessional education and seamless care. Right, it's not easy. Anyway, I have just shared a few practices, and I'm also learning from each other, basically. Right, I move on. Personal experiences as accreditation coordinator and assessor. The first slide here is basically my experience as the coordinator of accreditation. Basically, my role in the we call it panel of assessor technical working group, or rather the committee. Committee's role is to oversee the recruitment or recommendation of recruitment, training of assessors, and their appointment, as well as their allocation for assessment and accreditation exercises. And what I would like to share here, basically, I didn't really expect this, but it is very interesting to me. This is food for thought again for everyone. This is basically a dedicated committee that look into one aspect of accreditation, i.e. management of the assessors. All right, so here what I can share is that we are basically at the receiving end in the panel of assessor committee. We have to ensure that we ourselves understand the standard for training, and we understand the process for accreditation. And when it comes to probably the first 1 and 2 is, I won't go into depth, otherwise we cannot finish this discussion. This is probably about the same as what been shared by the Indian Professor Chako, right? And of course with minor nuances and minor differences. Right, but probably this is again probably the challenge that I would like to share. The experience of handling over 200 consultants and doctors who are being recruited, trained, and appointed as SICs, and managing the nuances. Basically, what the committee that I chair deals with the consultants. These are highly qualified specialists, and definitely just by that alone, you know that they are very busy. If they are in a university, they are probably professors or associate professors. They are senior lecturer and above, and definitely with teaching commitments, clinical commitments, etc., etc. They're very busy. And what more, quite a handful of them are the clinical specialists in the government service or elsewhere in the healthcare delivery system. and definitely it's not easy at all to have their time, their commitment, and their understanding of items 1 and 2 as well. All right, anyway, this is again, if you want details, it's a different sharing, but food for thought for everyone in your own country. Probably how have you been handling this, and probably what is the way forward? All right. Okay, I've said that the expertise, commitment, cost, and time to do all the above is very, very challenging as well. Right. Personal experiences as an accreditation assessor. I've been assessor for the undergraduate basic education, as well as postgraduate and other accreditation, other program accreditation. Of course, probably I've become assessor for about a few dozens, 3-4 dozens is I've lost count basically. But whatever it is, these 3 questions basically has always come to my mind. It's not an easy task to judge the quality of any academic program. And I've always asked myself, can this really 3-4 day scrutiny accurately judge the medical school quality and to come to a judgment, whether they get accreditation, don't get accreditation, and what need to be improved? Yes, that's very mind-boggling, but what I found myself, I learn as with every accreditation. Definitely there's new knowledge that I've gained, and probably I can share this as a motivation to all of you out there. I believe most of you are either trainee in medical education or medical educationists, and I'm sure most are also being recruited as assessors. It is a daunting job. It's not easy, but we learn, actually. We grow as we compare ourselves and our practices with other universities. But of course, we have to, again, we cannot be biased and come to a accurate judgment. Number 2 here, related to the above, I will not go into detail, but the item number 3 here, after each accreditation visit, I always wonder myself, will the quality that we have attested, that we have affirmed, continue after we leave the institution? Of late, basically in the last about 3-4 years or so, in Malaysia, basically sorry, I digress a bit, then come back to this. Similar with the Indian experiences now, our Malaysian system has made it compulsory to establish the internal quality assurance unit. But of course, we call it unit or department here. We do not call it cell, but of course, people come with different names. More and more, actually, whenever I become an assessor, I always look at the internal quality assurance system and their respective unit. And again, this is a great challenge. The people appointed as the chair of the internal quality assurance units or departments, either they are also busy clinicians, they are busy doctors, they are busy lecturers, so there's one, or they do not have basics in medical education, they do not have basics in quality assurance, and probably some much to be desired training as quality assurance personnel. So these are the a few questions rather than answers. I'm sorry, like the previous speakers, we have more questions than answers. And again, here are more questions.
Oh, I think Professor Young got disconnected. Professor Young, are you still with us? Okay, while we're waiting for Professor Young, thank you very much, Professor Young, for presenting her expertise. And there are already several questions in the chat box, and I would like to relay the questions to Professor Chaco. The first one is, how will you suggest accreditation bodies of medical and health professions education to put more emphasis on social accountability, particularly in addressing the disparity of underrepresented communities and geographical regions? Would you like to answer, Prof. Chaco?
Yeah, like Professor Charles Colin mentioned, most medical schools come up in context of the country's needs, and they're already responding to the societal needs. Only the words socially accountable, the medical school and all those things are not there in not recognized in the institution's core mission and vision statement. But if you read their vision and mission statements, some of the elements that constitute social accountability is already there. And so when the accreditation system includes it as a quality development standard within the accreditation and mentions social accountability as a standard requirement, then it is possible, at least in India, to encourage the medical schools to strive for social accountability through service, education, and research. So it is possible, but the direction has to come from the National Accreditation Agency and include this as one of the elements for assessment.
So there should be a framework first, right, Professor Chaco, and how to, especially if you have a lot of medical schools, just like in India and especially in Indonesia, we have more than 100. There should be a framework first on, especially on how to guide them to implement, let's say, the social accountability, and especially with a particular issue such as the communities and geographical regions. Okay, Professor Young is already here. Professor Young, would you like to also address the questions, or would you like to finish your presentation? Is there any?
I'm so sorry. This thing happened when we do things online. Suddenly I got cut off, really blank. I'm so
Yes,
sorry.
it's fine. It's okay.
Do we have time to go to just the last bit of what I would like to say? No,
yes, perhaps the last slide, and then we can continue to answer questions, since there are already several questions in the chat box.
Okay, yeah, so sorry about this. So I will just finish off, everyone. Hello back. I'm so sorry about this. This is basically my last few slides. Probably 50% similarities with the wish list of other speakers. Let me put this into the screen show. Okay, the way forward, that's the last bit. And one is to strengthen the external quality assurance system accreditation, let me rephrase, strengthen external quality assurance system, i.e. the accreditation system for member countries, which include better adaptation of the WFME standards, ensure robust but feasible accreditation processes. And the last bit, I feel very strongly, I think this also said by Professor Chaco, the quality indicators probably needs a lot of thoughts by everyone. We have said this again and again throughout today, outcome indicators, impact indicators, or clinical indicators, rather than using input indicators in accreditation judgment. Right, the way forward, this is again close to my heart, strengthen the internal quality assurance system of respective medical school. And it begins with inculcating quality culture in their own school and inculcating robust self-accountability in the medical faculty, the robustness of internal monitoring, and the good quality indicators, and using the internal quality indicators as a pillar of external validation or external accreditation, and definitely the capacity building of the internal quality assurance personnel, as I've shared just now. All right, the third point that I would like to probably propose everyone to think about strongly is the expert panel on quality assurance, i.e. who are the assessors basically, and what are the basic criteria and capabilities of being assessors, what are the training of assessors. In my wish list, to me, assessors should be specialists. They possess postgraduate qualification, definitely, as definitely all lecturers possess postgraduate qualification, but to me, ideally, they must possess some kind of certification in medical education, probably up to the level of postgraduate diploma, or probably the FEMA fellowship can be an alternative, right? How do we manage these assessors? They're very busy people, and how do we remunerate them well? How do we encourage them? Can we share expertise, cross-border, international sharing of, or inter-country sharing of assessors, and the cost involved? I think cost has been said again and again today, the cost involved in all this. All right, last but not least, we shall not forget about the basic medical education and the capacity building of each and every medical teachers, and finding balance between being subject expert versus being teaching expert. As we know, medicine is tough. What more in being a medical specialist? I've said about probably thoughts on compulsory certification as medical teachers, but this one, somebody has commented to me and said that, Prof Yong, don't be so tough because everybody will fail this. All right, and many of us are not trained. So anyway, these are a few other thoughts on how to make the content load and workload of every lecturer a bit easier, so that quality can be assured rather than quantity. So ladies and gentlemen, and Professor Rahma, that's all what I have to say. That's my contact, and thank you very much for your attention, and apologies again for the glitch in the internet line. Thank you.
Thank you very much, Professor Young. It's an inspiring presentation. I think there's a different, some of different practice, but mostly are giving the same message as the previous presentation, Professor Chako. We had a question here. I think it's for both of you. It can be applied. So I think I would like to hear from both of you, from Ibu Rilani. In the era of interdisciplinary education with emerging needs such as competence related to digital or information technology, how to ensure the education quality? I think I would like to hear from both Professor Chako and also Professor Young. Would you like to give your comments?
So it's basically about quality of interprofessional education?
Yes, interdisciplinary education with needs such as digital information technology, and to make sure, how to make sure education quality in relation to that.
Yeah, the question is very relevant, especially we are in the 21st century and the learners, the graduates that come out have to be 21st century skills ready. And since in the digital era, the changes that are happening are very quick. And the facts and knowledge that is available today quickly becomes obsolete. That applies in general, but in the case of interprofessional education, the importance is of interprofessional education is in terms of patient safety, ensuring patient safety and healthcare outcomes through teams. So the main purpose of introducing interprofessional education is that the various constituent team members of healthcare providers, they recognize each other's strengths. And so long back, the WHO said the interprofessional teams must have, as part of their curriculum, slots or modules where they learn together as part of their undergraduate curriculum, so that when they learn together, they learn how to work together. And so obviously we need, for the purpose of quality, whether the systems are in place, whether the curriculum is in place where there is opportunity to learn together, whether the timetable reflects dedicated time where there is opportunity for interprofessional learners to spend time together to solve and maybe in a simulated way arrive at outcomes and patient care, and they debate over it, and they reflect on the benefits of interprofessional education. And we need to arrive at criteria which will indicate the quality and the extent of interprofessional education that is being promoted within institutions. Thank you.
Thank you. Professor Young, would you like to comment?
Yes, thank you very much for the interesting question. To me, it's thought-provoking. Again, something close to my heart. But I would like to summarize my thoughts in just 2 points, basically. One, going back to basics. And number two, accountability of the educational provider. All right, so let me expand on this. One, going back to basics. Yes, in my journey as an assessor, as well as, as I said just now, I've seen a lot of programs. People are very excited about all these IT, interprofessional, PBL, TBL, all the jargon. Yes, they do all things. But what I see, actually, they just merely doing it, delivering it, teaching that way and this way, just because they were told by the dean, by the medical education unit, etc., without knowing why they're doing it. So that's one. Without aligning with the intended outcomes. They don't even know the outcomes, why they are doing certain things, and what more the assessment of the outcome of the teaching learning utilized. I.e. here, that's why I say going back to basics in any curriculum is always the alignment between the outcome, teaching learning, and the assessment. So what the message I would like to get across, yes, do whatever we have to do. Yes, we have to do good things, interesting, make the learners engage, but remember about aligning. Probably I'm reminding myself, and this is one challenge that I see very frequently in my encounters with medical program. All right. The second sort of thoughts on this is basically the accountability. Again, this very much related with the first thoughts, the alignment. Again, accountability is related to each and individual lecturer. Accountability related to probably the school management, as well as related to the quality assurance units or cell or whatever you call it. And here again, is about self-monitoring, knowing what you are doing. So that's one. About when it comes to the quality assurance unit, is probably monitoring of these different deliveries. And a good example is basically the IT. Using IT, during the pandemic, we use a lot of Zoom and etc. And what we found is probably without monitoring is the students, they just shut off the They are there, yes, they're there, but they just shut off the video and disappear somewhere else. And so again, and the lecturer continue and continue, and it needs the quality people to say, look, where are the students, that kind of thing. So again, of course we can go on and on, but probably people will remember there's two main messages about this. Remember the basics: alignment between the intended outcomes and the teaching learning approaches and methodologies that are used, and its assessment. And number one, accountability in doing all this. Professor Rahma, sorry, I hope that's not a lengthy answer.
Thank you very much.
you.
And I think, as you all said about how to, let's say, improve the practice also actually by using the technology. And I think this is the last question. I think will be very, I think it's a very nice wrap up for both all the speakers from WIASI to address the issue of health transformation, the latest health law in Indonesia that medical schools previously held by universities become hospitals as the main organizers. This is especially for the postgraduate or specialty or residency trainings. So we become from university-based, move on to the hospital-based education. And how is the accreditation process, especially in quality assurance of graduate and ensuring patient safety done well? So I think the highlight here is that how when we have different stakeholders or changing organization or management, how to stay faithful, let's say, to the concept of ensuring our graduates and patient safety. I would like to invite both Professor Young or Professor Chako first.
Yeah.
Okay.
You go.
Sorry,
Yeah. So as part of the accreditation process, there is a recommended involvement of all stakeholders. The students, the management, the teachers, the patients, and so by getting their perspectives and eliciting feedback from them, as well as getting feedback from the alumni of the system, the institution, as well as the employers of the alumni, or the postgraduates. So the supervisors of the postgraduates and the managers of the health system or even the hospital where the graduates are working. So getting their perspectives, what they are doing well and what needs to improve, that kind of input when we receive, the internal quality assurance cell of the unit can deliberate on that and discuss it with the system within the institution by pointing out these are the observations. How will you respond and ensure that the expectations are met? Similarly, patient care and quality outcomes, perusal of, say, the complaints from patients or quality audit or patient care audit, all those things, when you include and study in the IQAC or internal quality assurance cell, they will provide important insights as to the areas where the institution is doing well and perhaps identify the gaps which need to be addressed. Thank you.
Thank
Yes.
you.
Yes, I agree with that. Maybe I just reword it a little bit. And in my perspective, basically in my country's perspective or the region perspective is basically faculty development. We have a standard on that. And faculty development also involves the supervisors, whoever trainers, people who supervise the students, be it for the undergraduate or postgraduate at the clinical training sites or hospital. This is sometimes easier said than done. the training, the clear instruction to the people at the hospital on what to do with the trainees or the students, and how to train them sometimes can be overlooked. So that's one. And again, in this region, one of the issues about getting the clinical outcome indicators, because the hospitals usually, the training sites usually belongs to another organization, right? It belongs to the government. Even within the government, for example, in Malaysia alone, we have the government university, a private university. What more if the private university, they have to go to the government hospital, and to get the quality indicators or clinical indicators very, very daunting unless there's some willingness to reform the system. All right. Okay. I hope that's clear.
Thank you very much, Professor Chaco, and also Professor Young, for sharing your thoughts. And I think the discussion wrap up the whole presentations, which I'm really glad to hear about the practice of accreditation in India and also in Western Pacific, and especially in Malaysia, since there are similar contexts that we share, and similar maybe more like societal needs and also what the public expect from medical education these days. I am informed that Prof. Titi is currently joining us. Prof. Titi?
Yes, hello. Yeah.
Yeah, Prof. Titi, would you like to conclude the webinar? And I think we currently have Professor Chakwa and Professor Young as the last speakers. And to close the webinar, I would like to invite Prof. Titi to share her closing remarks.
Yes. Once again, I would like to express my gratitude and high appreciation to all the speakers, Professor Jenny, and then Professor Charles Bullen, Professor Thomas, and Professor Young, to spend time with us, to share ideas, and to have conversations about these important issues. And of course, there is no one single answer for all the issues that we have discussed, and things are developing and moving very fast. So it is a very good platform if we can continue these conversations among the region, among other countries, so we can be enriched and we can be inspired of what other people have done, have been doing. We can learn from each other. Once again, thank you very much, and I hope that what have been explained by all speakers, it inspires all the participants, and we look forward to continuing these conversations and dialogues. Once again, thank you very much.
Thank you very much,
Very much. Well done.
Prof.
And
Titi.
Titi, drive
Yeah.
safe.
Thank
Are
you.
you driving?
Thank you.
She's a passenger.
Okay.
And congratulations, Prof. Titi.
Thank you
Yeah.
so much. Thank you so
Congratulations.
much.
Well done. Well done, everyone.
Yeah, inshallah.
Thank you so much.
Thank
Thank you
you.
very much. Our deepest gratitude to our speakers, honorable speakers, and also dearest participants. Thank you very much for joining us in today's webinar. Also representing Prof. Genevieve and also Prof. Charles Bullen, who already, I think they already had a good rest, hopefully. And see you in another webinar, and especially how we will work together in collaboration to improve the quality of our medical and health professions education. Congratulations once again to Professor Titi Savitri for the inauguration tomorrow, and hopefully everyone will be in good health. Thank you very much. I'll see you next time. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much.
Waalaikumsalam. Thank you very much. Rahmat. Thank you all. Bye-bye.
Thank you.